Hello, dear students. Today our topic is alteration of endocrine function, and we are going to discuss about one of the most important system which is participate in regulation of different body functions, regulation of nutrition, maturation, regulation of enzymatic activity, growth, development, and some other functions. And today we try to discuss about the main principles of regulation thanks to endocrine system, the main etiological factors which can cause disorders of endocrine system, and try to discuss about the common pathology which is associated with hypo or hyperfunction of endocrine system. So our agenda today includes the next points. The general definition about endocrine system, then definition hormones and its function. Then we have to discuss about the mechanisms of hormonal alteration, and we'll discuss about the alteration of hypothalamus, pituitary gland, adrenal gland, and touch the pathogenesis of stress because it's strongly associated with endocrine function disorder. And most important things which I have to tell you today, that you have to remember that endocrine system together with the nervous system acts as a body communication network. It is composed of various endocrine glands and endocrine cells. And the glands are capable of synthesizing, of releasing special chemical messengers, hormones. Usually we have to tell that hormones are specific substances which are secreted by specialized cells in very, very low concentration. And they able to influence secreted cell itself. And we know this as an autocrine influence. And also it can influence removed cells, and we have to tell here about the hormonal influence. Or sometimes it can influence adjacent cells, and we know it as a paracrine influence. Usually endocrine function includes regulation of different body functions such as growth, development, maturation. It participates in releasing of reproductive mechanisms, nutrition, performance of adaptation of organism in different extreme conditions, and generally it helps to maintain of homeostasis. And when we discuss about the principle of influence into all these different functions, it usually integrated by both central and humoral factors. And finally we have an releasing of signals which regulated by higher center of the brain, which is hypothalamus. Hypothalamus functions includes different moments and principles. The most important thing that hypothalamus acts as an integrative center for both autonomic nervous system and endocrine system. It controls some endocrine glands by both neural and humoral pathways. And it participates in releasing of different kind of hormones which can influences both by stimulating factors as in stimulating factors as in inhibiting factors. Key to understanding the endocrine relationship between hypothalamus and anterior pituitary, appreciate the vascular connections between these organs. Secretion of hormones from anterior pituitary is under strict control by hypothalamus hormones and reach the anterior pituitary through the following route. The branch of the hypophyseal artery ramifies into capillary bed in the lower hypothalamus, And hypothalamic hormones distinct for the anterior pituitary are secreted into the capillary blood. And blood from those capillaries drains into hypothalamic hypophyseal portal veins. Portal veins are defined as veins between two capillary beds. The hypothalamic hypophyseal portal vein branch again into another series of capillaries within the anterior pituitary. Capillaries within the anterior pituitary which carry hormones secreted by the glands coalesce into the veins that drain into systemic venous blood. Those veins also collect capillary blood from posterior pituitary gland. And when we discuss about the regulation by hypothalamus, it associates with hormonal hierarchy, where the first stimulus associates with different factors. It could be different external stimuli or some influences from the neocortex or different homeostatic mechanisms, which finally leads to influence into hypothalamus, and it direct influences pituitary with the trophic influence into the different peripheral endocrine glands such as kidney, thyroid and parathyroid gland, ovary and testes. According to the influence and interaction between autonomous nervous system, whereas the hypothalamus also one of the main factor of regulation, it also influences adrenal cortex and pancreas. And finally, the result of this stimulus and interaction we see in realization of different body functions such as in body temperature, water and salt balance, reproduction system, etc. And everything is controlled by the releasing of a specific group of substances which has different source and different structure, and which we know as in hormones. So what are hormones? Usually it's substances which is associated with very low level of concentration, and it could be synthesized by different types of cells such as neuroendocrine cells when we discuss about hypothalamic hormones, by epithelial cells, one's own glandular epithelium, or sometimes hormones could be synthesized by myoendocrine cells, such as a natriuretic hormone or natriuretic peptide, which produced by muscular fibers of right atrium. We know that hormones should be classified into different groups according to its chemical structure, and I hope that you're familiar with this from the course of biochemistry. And we divided usually hormones into three groups, such as steroid hormones, derivatives of amino acids, protein and peptide hormones. When we will discuss about the particular examples of different hormones, as in protein and peptides hormones, usually we have to tell about oxytocin and vasopressin, all group of releasing hormones, insulin, glucagon, calcitonin. Steroids hormones are mineral and glucocorticoids, and both female and male sex hormones. And as a derivative of amino acid, we have to tell about the catecholamines, melatonin, and thyroid hormones. Another kind of classification of hormones includes its influences into the factors and into the target organs and cells. So according to these functional effects, we have to divide hormones also into three groups, such as effectors, which can directly act into the organ or target cell. Second group is the tropic hormone, which participate in regulation of synthesis of effecting hormones such as an ACTH or TTH. And the third one is releasing hormone group, which participate in regulation of synthesis and secretion of tropic hormones, like, as an example, corticoliberine or some other releasing hormones. Another kind of classification includes summarizing of hormones into different groups, such as in groups of gastrointestinal hormone, such as in group of opioid peptides, different tissue growth factors, such as an epidermal growth factor or nerve growth factor, separate hormone with specific action, which we mentioned already, atrial natriuretic hormone or natriuretic peptide, different endothelial factors such as endothelins, transforming growth factors and hematopoietic or other growth factors. And also we have to tell about the cytokines such as interferon and tumor necrosis factor, also as a specific small but very important hormones which is participate in regulation of different function in immune response and in protection. We have to remember that we have to differentiate hormones according to its ability to transportation into the freely circulating hormones, which usually rapidly removed from the bloodstream, and bound to transport proteins, hormones, as an example, albumin, transcartin, or globulin, which usually associate with bonding of hormones to this transport protein, and then these hormones could be transported to some target organ. When we discuss about the principle of mechanism of hormone influence, the most important thing is this specificity, high level of specificity between hormone and its interaction with receptor. So each hormone's shape is very specific and it could be recognized by the corresponding target cells, and could be different situation with this interaction of hormones with its receptor, because some types of hormone can cross the membrane and bind to the receptors in cytoplasm or even in nucleus. But some types of hormones cannot cross the membrane to enter the cell, and receptors for such kind of hormones are located on the surface of a cellular membrane. As an example, peptide hormones mostly associate with the second type of interaction. Steroids hormone and thyroid hormone associates with interaction with receptor in the cytoplasm or nucleus. And here we have to tell about the interaction of hormones and realization of its function thanks to the interaction with secondary messengers. So let's see that usually first messenger or ligand interact with membrane receptor, and thanks to G proteins we have the influence into the effector, some kind of enzymes, and it helps to activation of secondary messengers, which help to realization of the program. It could be activation of different kinases, it could be activation of different cascade of cellular response, which finally leads to different metabolic and structural changes. And here we have to tell that usually receptors for glycoprotein and peptide hormones and for catecholamines are situated on the outer surface of the target cellular membrane. As an example of these secondary messengers or second messengers, we have to name different CAMP, CGMP, calcium calmodulin, diacylglycerol, and inositol triphosphate. And when we discuss about the another mechanism of interaction, we have to tell that, as an example, steroid hormones can pass through the plasma membrane, and it binds to the receptors in the cytoplasm and leads to activation this kind of plasma proteins. And we will see formation of hormone receptor complex which enters the nucleus and binds to specific genes. And finally, this stimulates the transcription of gene into mRNA, and finally it leads to translation into specific protein which participate in realization of the hormone function. So you have to understand that some group of hormones participate in interaction inside the cell receptors and sometimes in its cellular membrane, and different pathology could be and realization of the program of hormonal regulation could be associated with a peripheral level, and this peripheral level includes the amount of receptors, level of affinity of receptors, level and function of secondary messengers, or some releasing of different enzymes. And in each step of this interaction could be damage, which finally this damage can lead to clinical endocrinopathy. And when we discuss about the formation of full picture of regulation, which is associated with the hormonal hierarchy, we have to revise your knowledge about this hierarchy, which is associated this central level, level of pituitary gland and releasing of different pituitary hormones, a level of different peripheral endocrine glands, and finally different target organs. And if we are going to discuss about the hormonal hierarchy, you have to remember that, as an example, a hypothalamic message is transduced into hormone release from anterior or posterior pituitary. And most of anterior pituitary hormones control peripheral or target endocrine glands, from which end hormone such as an T3, T4, such as an testosterone, such as aldosterone could be released. And regulation of this hierarchy link and endocrine function finally associates with feedback control. And it's easy, and hope that you remember how it works. Usually we have two negative feedback regulation mechanism when the stimulus is decreased by the response, and most amount of hormones function, humoral function, associates particularly in negative feedback. But sometimes we can see the positive feedback when stimulus can be and can lead to amplification by the signal. And schematically, I think that it will be more clear for you. We have to explain how it works. Let's see, as an example, when we discuss about the negative feedback. Releasing hormone of the hypothalamus, as an example, corticoliberine, elicit the release of the corresponding tropic hormone from the arterial lobe of the pituitary gland, as an example, ACTH or corticotropin, which is in turn influence the peripheral endocrine glands such as adrenal cortex. And the end hormone here in this situation is cortisol. Not only acts on the target cell, but it also inhibits secretion of the releasing hormone in the hypothalamus, which result finally in decrease in the amount of end hormone set free. And it works, and it's one of the main mechanisms of regulation. And the level of end hormone and level of tropic hormone can help us to make diagnosis for the patient, as an example, and can give us feedback. Is it the problem with peripheral endocrine gland, or it's some problem with higher level, as an example, disorders in pituitary gland or even in hypothalamus. And also you have to remember that our influence into the endocrine gland is higher, and sometimes this kind of influence could be associated with different not only natural endocrinopathy, but could be associated with iatrogenic endocrinopathy, so caused by doctor. And let's see into this picture. Sometimes for anti-inflammatory influence we have to use different hormones, and mostly cortisol. And when this kind of hormone is given as a medication, it causes reduction in the secretion of corresponding tropic hormone. Here it will be ACTH. And in the same way as does the natural hormone, in our example cortisol, which is produced by the adrenal cortex. And chronic administration of the end hormone or of one of its derivatives, those results in inhibition and atrophy of the gland that normally produced it. So we will see compensatory atrophy. So when you administer glucocorticosteroids for patients with chronic inflammation, for patients with systemic lupus erythematosus, for some other patients who need administration of glucocorticoids, you have to remember that long-term and chronic administration can lead to compensatory atrophy of adrenal cortex. And your patients also have to remember this, because acute refusion from such kind of therapy could be characterized by crisis, because even increase of tropic influence unfortunately cannot substitute this level of glucocorticosteroids, and patient can suffer from iatrogenic endocrinopathy, which sometimes could be fatal or could be very dangerous for patient's life. This example shows us that sometimes we see not only some pathology associates with tumor development or blood flow disorders, but sometimes it could be associated with side effect of the medicine, and you have to remember about the strong link between pathophysiology and pharmacology. And when we are going to discuss about the particular disorders, so what are the manifestation and what are the principle of the influence of hormones into the target cells, we have to remember that regulation of the metabolism could be thanks to the different ways. First of all, hormones influences and leads to changes in enzyme configuration. And finally, it results in direct alteration in the enzyme activity. We know this mechanism as an allosteric mechanism. Sometimes it could be associated with changes in enzyme synthesis, and we know this way as an induction. And sometimes alterations in the substrate availability for the enzymatic reaction, such as by changes in cell membrane permeability. So different effects, different kind of influences, which can lead to realization of the final function of hormones, such as an stimulation of the transport of glucose or amino acids, influence into the ionic transport across the cellular membrane, influence of epithelial different transporting mechanisms, stimulation or inhibition of enzymatic activity, and influence the cell genetic information. So all kind of these final effects associates and depends on endocrine function. And any kind of endocrinopathy could finally lead to disorders in metabolism, and it's very important. And when we discuss about different kind of endocrinopathies, it usually includes different disorders in one disease. As an example, you're already familiar with diabetes mellitus, and you know that deficiency of insulin or problems with realization of insulin interaction with receptors finally leads to disorders of not only carbohydrate metabolism but also acid-base balance and fat metabolism and water-salt balance and even protein metabolism. And when we discuss about the endocrinopathy, is usually complex of metabolic disorders which could be realized by disorders of these general effects of hormones. And what are the etiology? What are the causes of endocrine disorders? First of all, we have to tell about the different external factors, such as bacterial infectious or viral infections, such as an influence of ionizing radiation or trauma, and sometimes different social or psychological influence also can lead to endocrinopathy because of this direct link between nervous system and endocrine system. But also a group of internal factors also can lead to endocrinopathy, and usually it associates with different blood flow disorders such as an thrombosis or embolism, which can lead to necrosis. Sometimes it could be different tumors, both malignant and benign, influence endocrine gland. Different chromosomal or gene defects also can lead to endocrine disorders. And a group of alimentary factors such as a deficiency of cobalt or iodine, disorders of consumption of different nutrients also influences synthesis of hormones and finally can lead to endocrinopathy. According to the changes of increase or decrease of hormone function, we divide it into three groups. Usually endocrine disorders could be classified as an hyperfunction, as an example, hypothyroidism or hypocortisolism, into the hypofunctions, such as a low level of releasing of thyroid hormone or sex hormones, and dysfunction, which is usually characterized by different changes of hormonal production and production physiological active precursors of their biosynthesis in the same endocrine gland or synthesis and entrance in blood of atypical hormonal products. And you already familiar with this type when we discuss about liver cirrhosis and pathology of endocrine system, which is associated with liver failure, when we have the situation of dysfunction and formation of different atypical hormonal products. As another example could be atypical hormonal products produced by some tumor cells, and we know this as an functional atypism of tumor cells, also linked with previous topics. Another kind of classification of endocrine function includes the mono or polyglandular pathology. So sometimes we see some problems with one peripheral gland, as an example, Graves' disease, hypothyroidism. But sometimes when we discuss about Sheehan syndrome or Simmons cachexia, when patients suffer from pathology of the pituitary gland, according to this hierarchy and group of tropic hormones and plenty of endocrine, peripheral endocrine glands which associate with this hierarchy, we have the patient with involvement of different endocrine gland pathology. And we know about the pluriglandular or multi pathology. And one more kind of classification includes disorders of partial and total. So it could be some problem with one kind of hormone, as an example, hyper aldosteronism and increase of only level of aldosterone by adrenal cortex. But sometimes we see the tumor or some another situation which involve all adrenal cortex, and we see changes of all kind of hormone, both increase or decrease level. And let's move to the situation, and let's move to the important point when we have to discuss about the pathogenetical possible mechanisms of hormonal alteration. So final disorder, hypo or hyperfunction, could be caused by different level of injury, and it is very important. First of all, it could be associated with failure of feedback mechanism. So some disorders of negative feedback, some disorders of feedback control can lead to pathology. Then dysfunction could be associated with different pathology of endocrine glands or cells, and we have to divide this point into the three one. First of all, sometimes secretory cells are unable to produce or do not obtain adequate quantity of required hormone precursors, and it finally leads to pathology. Sometimes secretory cells are unable to convert the precursors to the appropriate active form of hormone, and finally we do not have the hormone function. Sometimes secretory cells may synthesize and release excessive amount of hormones, and finally it can lead to increase of its function. The next group associates with the level of and efficacy of degradation of hormones, and it also familiar for you situation with liver failure. So low level of inactivation of insulin because of lack of insulinase can lead to hyperinsulinism and hypoglycemia finally in patient with liver failure. And sometimes it could be inactivation of hormones by antibodies before it reaches into the target cell, and we have another situation, kind of alternative situation. One more problem could be associated with formation of ectopic sources of hormone, as an example, tumor of the lungs could be as a source of different kind of hormones, and this ectopic source influence endocrine function. Also, we have to tell about some disorders in hormone transport, reception, and hormone metabolism. When we discuss about hormone transport, it also could be final hypo or hyperfunction because of lack of transport protein, as an example. Decrease hormone binding and increase in blood concentration of free form of hormone and hyperfunction finally. And we stopped already in these mechanisms, which is associates with interaction of primary messenger or hormone with its receptor. So pathology also could be caused by disorders or receptor associated disorders or intracellular disorders, which finally leads to impaired endocrine function. When we discuss about the receptor associated disorders, it could be some routine situation with decreased amount of the receptors and finally decreased hormone receptor binding. It could be decreased sensitivity to hormone because of impaired receptor function. Sometimes it could be formation of antibodies against the specific receptors. Or it could be unusual expression of receptor function. And all of these factors can lead finally to endocrinopathy. And when we discuss about intracellular disorders, it could be associates with inadequate synthesis of secondary messengers. Then number of not only extracellular but intracellular receptors also may be decreased, or they may have altered affinity for hormones. And even previous steps is okay. Sometimes intracellular disorders can include alteration in generation of new mRNA or absence of substrate for new protein synthesis, and it can finally lead to endocrinopathy. So let's see that in spite of level, we can have endocrinopathy according to the different pathogenetical mechanism. Since the centers like hypothalamus or pituitary till intracellular receptors or some enzymatic activity or level of the secondary messengers. And all of these steps very strongly and logically associates with each other, and in each kind of this thin link could be some disorder which finally can lead to endocrinopathy. So the endocrine system is very beautiful system to my mind. It very logically constructed, but very, very thin and very susceptible to different influence. And we have to be very careful with our patients because you have to understand that in each kind of this step and each kind of this link, this system could be broken down. And we have now to move to some specific pathology, and we have to start from the alteration of hypothalamic pituitary system because it's the huge group of pathology. It associates with hypothalamic disorders, with pituitary system disorders, and you understand that it also involves the peripheral endocrine gland manifestations, and it associates with different etiological factors such as an destructive lesion of the stem. Sometimes it could be head injury and finally rupture of the stem, surgical transaction, and tumor. And now we have in some 5 minutes video which tell us the information from the physician, from the patient and her mother about the clinical picture of patient with hypothalamic tumor. And let's see this dramatic history.
I'm Mia. I'm 14 years old and I love singing and dancing. I can see a rainbow, magical rainbow in the sky.
What do you like about that song?
I was around when I had eyesight. We didn't know about the tumour at the start, and when we found it, it was the size of an orange.
A tumor is just a lump. Usually people refer to benign brain tumors when they tend to grow slowly and they don't spread around in the rest of the body. However, I think this term can be misleading because people might think that benign means harmless. But benign brain tumors are anything but benign. If they come in the wrong location, they can be even more detrimental than malignant brain tumors. This is because usually they happen to be in the middle of the brain, which is very difficult to access from a surgical point of view.
Benign is a funny word because, you look up benign, it means harmless, and then you look at all the effects it's had on Mia and many other children in Mia's situations, and it's caused so much harm and so much damage that can't be. You always bandage up your toys, so this one did have a bandage on her head, didn't she?
Now it's on her foot.
Now it's on her foot.
I do it a lot.
You do? You're always asking for bandages when you're in hospital, don't you? It's a tumour that's real deep in the centre of the brain where the sort of optic pathway sort of cross, and it's dead in the centre because it's where the hypothalamus is. It's like the control centre of the brain.
So the hypothalamus is actually one of the most amazing structures of the human brain. Tiny in size, hidden in the middle of the brain, but displaying essential functions for the human survival. So despite being tiny, is a very, very important part of the human brain.
It's impacted pretty much on every aspect of her life. So obviously she's completely blind now, so no light perception, no nothing. But she's also got a number of other issues. So she doesn't really sleep properly, which again they're saying is, the sleep regulation is controlled by that part of the brain. Her temperature regulation's gone completely out of the window now. She used to love drinking, apple juice, orange juice, water, whatever, but now she just does not drink. So because she doesn't drink, she's recently, last week, she had a gastrostomy put in, which is basically a tube that goes directly to her tummy. Her quality of life is really hard at the moment, so.
Now oncologists treat more than 80% of so-called benign brain tumors, and we're only now recognizing that these children have so many unmet and complex needs, and some of them were unpredictable and they go really beyond the cure of the actual tumor. If I was a child, probably I wouldn't really consider myself cured if I need to go to the hospital for the rest of my life.
When she was diagnosed, she had obviously the shunt put in her head to relieve the pressure, and then she had 18 months of chemo. And we had 4 sort of fairly stable-ish years really, but throughout those 4 years, although it was stable, they were saying it was stable, actually the whole time it was growing slowly. So really she has been on and off chemo now since the beginning. And she's had, like last year, she had 10 brain surgeries to try to get things under control. But it's just been quite relentless, really. It's not about curing anymore, it's just about managing everything and making sure she's getting everything she needs, all the medication she needs and everything to help her live, as close to a life that we'd have envisioned for her.
So the key aim of my research is to improve diagnostic accuracy of this condition, so to make a diagnosis early. So the images that I'm taking try to look better at the size, shape, volume, structure, perfusion and function of the hypothalamus and the pituitary gland. We hope that better imaging tools will help the surgeon to see where is the damage so they can develop better surgical strategies to preserve the hypothalamus. The hormones that I'm testing are related to thirst, hunger and behavior. So I hope that a better understanding of the condition will inspire future research on developing better medical treatments for these kids. We are funded by two charities, Success and Children with Cancer UK.
You know, if we can get earlier diagnosis and more understanding of these things, then you know, it could have a huge impact and mean that another child doesn't have to go through as much.
Have you ever met Manuela before, Mia? So she's trying to help reduce the side effects for children and young people like you.
Really?
Yeah.
How does that make you feel?
Special.
So you have to understand that in spite of etiological factor, necrosis, tumor, or some rupture of stem associates usually with damage of different body function, and it's one of the example of pluriglandular endocrinopathy. And it's clear why it happens, because it associates with this integrative function of the pituitary. And when we discuss about the type of hormones which produced by pituitary, we usually have to differentiate them into anterior and posterior, and only two hormones produced by posterior, but really they produced by neurohypothalamus but released in pituitary. It is an ADH and oxytocin, and other it's the group of tropic hormone and also melanocyte stimulating hormone, prolactin and luteinizing hormone and different gonadotropins. And when we discuss about the pathology of posterior pituitary, mostly two hormones which we know as in really hypothalamic hormones released by, and pathology could be associated or with hyper and hyperfunction of ADH or some pathology of oxytocin. But with oxytocin, not so lots of information now. We only know that both ADH and oxytocin are synthesized as in prohormones and proceed into nanopeptide, so includes 9 amino acids. And oxytocin participate in different function, but pathology of oxytocin is unclear and one of the questionable history, because now we have some information about the oxytocin disorders as a possible pathogenetical factor for autism development, but more amount of information about the ADH pathology, and we usually subdivided it into hypofunction or diabetes insipidus and hyperfunction, or we know this as a syndrome of inappropriate antidiuretic hormone synthesis. So it's one of the rare disorder, and it associates usually with high level of ADH in absence of normal physiological stimuli for its releasing. And when we discuss about the etiological factors for inappropriate ADH secretion, usually these tumors, trauma, inflammatory disorders, some hereditary causes, and could be damaged during surgery. When we discuss about the pathogenesis of syndrome of inappropriate ADH secretion, it associates with higher level of ADH. And according to main function of ADH, we will see the water retention and increase of total body volume. total blood volume too. And finally, it leads to disorders of water salt balance. We will see hyponatremia and hypoosmolar state, and it is not true hyponatremia. It's partially associated with decrease of aldosterone production, but also it associated with a higher level of water, and it associated with delusional hyponatremia. It leads to suppression of renin production and continued decrease of aldosterone production and decrease of reabsorption of sodium in kidney. So what are the symptoms of inappropriate ADH synthesis? Firstly, it's the water retention, and the patient can suffer from solute loss, particularly sodium, and patients suffer from hypoosmolarity, and it characterized by osmotic inactivation of cellular solutes. Antagonistic situation for inappropriate synthesis of ADH is diabetes insipidus when we discuss about deficiency of ADH. And there are three forms of this disorder: neurogenic or central, which associate with damage of ADH production, so some problem with hypothalamus or neurohypophysis; nephrogenic form, which is associated with sensitivity of epithelial cell receptors of distal nephron to ADH, and this sensitivity is reduced. And sometimes we see psychogenic form with an increase of intake of fluids, and it leads to inhibition of ADH production. Insufficient ADH secretion causes immediate excretion of large volumes of dilute urine and leads to increase of plasma osmolarity, so vice versa to previous syndrome. And when we discuss about the symptoms, patient firstly react into this increase of plasma osmolarity by increase of thirst, so stimulation of thirst center, and patient became suffer from polydipsia. Also, urine output usually it is varied, but in about of half of cases, urine volume is 4 to 8 liters per day, while in 1/4 of these cases it even more, so it could be 8 to 12 liters per day. And this patient became eat more and more, and when we discuss about the laboratory characteristic of the urine, it usually characterized by decrease of specific gravity of urine, decrease of osmolarity, and it influences cardiovascular system too, so we will see decrease of BP and tachycardia. As in symptoms also, we have to mention polyuria and nocturia, and high plasma osmolarity level. When we discuss about the prognosis for patients with diabetes mellitus, and one more thing, why this disorder is also diabetes as in mellitus. Both of these diseases are characterized by polyuria. It is a common symptom. And one more common sign of both this diabetes is development of the hyperosmotic hypohydration, so increase of plasma osmolarity together with decrease of total blood volume, but completely different etiology, pathogenesis, and some other factors. And when we discuss about the prognosis for the patient, it depends, because for some kind of situation it could be treated when we discuss about some central form or psychological disform, but sometimes it's very difficult to treat. And let's move from posterior pituitary into anterior pituitary, and we also have to differentiate it into the hypo and hyperfunction. And usually we have to differentiate it to primary and secondary. Primary, it associates with intrinsic pituitary disorder, and secondary, it's something which is caused by hypothalamus function, or could be functional problem in different situations such as anorexia nervosa or chronic starvation. When we discuss about hypofunction of the pituitary, it could be characterized by partial and total disorder, and total disorder associates with few syndromes such as an Simon cachexia, Sheehan's syndrome, and chromophobe hypophysis adenomas. So we have to tell about in all these three forms that we see decrease of formation of all hormones of anterior pituitary. And clinically manifestations we see when the lesion of anterior pituitary more than 75% of glandular tissue loss, and complete clinical manifestation when the 95% of adenohypophysis is damaged, so high level of compensation of function of hypophysis, but unfortunately severe lesion finally leads to the clinical manifestation, and let's see how it is dramatic. Simon's cachexia usually associates with vascular lesion or tumor, and characterized by a full insufficiency of anterior pituitary function. And the clinical manifestations are asthenia, loss of weight and loss of hair, hypotension, and manifestations of pluriglandular insufficiency, which includes of thyroid, adrenal, and gonadal hypofunction. Another one syndrome, it is in Sheehan's syndrome or postpartum pituitary necrosis. Usually we see a development of this disorder because of ischemia during hypotensive episode during delivery. The normal blood loss, it's about 400 milliliters, but when the woman suffered from increase of blood loss 1.5 to 2 liters, it's the higher level of risk of development of Sheehan's syndrome. And the same with clinically manifestation, it's the multiple disorders, which includes of level decrease of ACTH level, decrease of the thyroid hormone function, diabetes insipidus, and unfortunately loss of reproductive function and gonadal failure because of lack of follicular stimulating hormone and luteinizing hormone. And it isn't, both of these syndromes are rare, and usually more commonly we see the selective hypopituitarism, such as insufficiency of TTH, insufficiency of ACTH, or deficiency of gonadotropic hormone, which can result in eunuchoidism or some disorders in spermatogenesis in men. When we discuss about this selective disorder, we have to move to hyperfunction of the growth hormone. As an example, is one of the most prominent hormone produced by anterior pituitary, and we have to tell about the firstly normal action of this hormone, because there are lots of metabolic processes associated with normal growth hormone function, such as skeletal growth, muscular growth, it participates in synthesis of proteins and uptake of amino acids, and it can lead to decrease of storage of carbohydrates and increase use of lipids for energy production. And let's see how many different influence of growth hormone into target organ and system, which finally leads to participation in cartilage formation and skeletal growth, different anabolic effects, and it participates also in carbohydrate metabolism. And when we discuss about the clinical manifestations, usually there are two situations which is associated with or hyperfunction or with hypofunction. When we discuss about the excessive secretion of growth hormone, it manifests or with acromegaly or with gigantism. When we discuss about the acromegaly, it occurs in adults who are exposed to excessive level of growth hormone, and it usually develops around the 30 years in both male and female. If increase the level of growth hormone starts in children, we see gigantism, and the patient looks like this. Let's see how many pictures with this lady who suffered from gigantism. So what are the common clinical manifestations? For acromegaly, we divided abnormal hormone production or a situation with abnormal cellular sensitivity. And clinically manifestation associates with cartilages, areas of skeleton enlargement, with enlarged lower jaw, with bone shape changes, with some broad facial features, and with increase of influence of growth hormone into different kind of the metabolic processes. So this kind of patients suffer from usually hyperglycemia. We know this is in secondary diabetes because of increase of the blood glucose level. Then these patients also can suffer from disorders in skeleton. Patients usually suffer from hypertension, cardiomegaly. Also such kind of patient can suffer from sexual dysfunction, peripheral neuropathy, and have some specificity in appearance, such as of this visual fields defect, and see what are the changes of patient's appearance we see after the presentation of disorder. If we are going to discuss about the antagonistic situation with a decreased amount of growth hormone or growth hormone deficiency, this is a rare disorder which is characterized by decreased secretion of growth hormone from the anterior pituitary. And according to the etiological factors, deficiency of growth hormone could be characterized by presence of genetic mutations. Then it could be associated with different acquired etiology, or sometimes it could be even idiopathic. Clinical manifestation could depend on onset of the disorder, such as in situation with acromegaly and gigantism. If it develops in childhood, as in clinical manifestations could be short stature, delayed maturation, and sometimes growth retardation, but without usually mental retardation. And such kind of patient characterized by proportional stature. If growth hormone deficiency develops among in adults, it could characterized by osteoporosis development, could see reduced muscular strength, also increase of low density lipoprotein and higher tendency to the development of atherosclerosis, and also some kind of altered body composition. And you know that this kind of disorder we usually name as a dwarfism. But according to the type of stature, according to the etiological factors and mechanisms of pathogenesis, we have to tell about two kinds of dwarfism. One of them is proportionate and growth hormone deficiency here, and you see this the right picture. And sometimes we will see disproportionate type of dwarfism, usually characterized by as an etiological factor achondroplasia, and it's characterized by some average size part of the body and some shorter than normal parts of the body. And let's see it is in the left part of the slide. And lots of other disorders of anterior pituitary we can tell like as a deficiency of ACTH or deficiency of TTH and vice versa, increase of releasing of such kind of hormones. But the clinical manifestation will be associated with the decreased level of end hormone. So we have to tell about Cushing disease or Cushing syndrome or some thyroid disorders. So it makes sense to move to the peripheral endocrine gland pathology, and we are going today to discuss about the alterations of adrenal gland. And according to the previous information, you hope that understand that the same way we have to differentiate pathology of adrenal gland into hypofunction and hyperfunction. It's from one point of view, and from additional point of view, we also have to differentiate it to the problem with one or two kind of hormones and with damage of all adrenal cortex as an example. And if we will tell about particular syndromes, in situation with hyperfunction, we have to tell about Cushing syndrome, which is characterized by high level of production of glucocorticosteroids. Sometimes we have to tell about Conn syndrome or primary hyperaldosteronism. And one more syndrome is adrenogenital syndrome, which is associated with virilism or hyperfunction of production of androgens by adrenal cortex. But you have to understand that all these syndromes associate with primary disorders. But sometimes manifestations of Cushing could be associated with the secondary type when it increase of level of ACTH, or even it could be like third level and tertiary kind of endocrinopathy when we have to discuss about increased level of corticoliberin. And antagonistic situation with hypofunction. And we have to start now from the Cushing syndrome and disease pathogenesis, and we will see the small video with an explanation and with lots of picture of development of main symptoms and pathogenetical mechanisms of Cushing syndrome. So let's see.
Cushing syndrome, named after the famous neurosurgeon Harvey Cushing, who first described it, is an endocrine disorder with elevated cortisol levels in the blood. In some cases, Cushing syndrome results from a pituitary adenoma making excess ACTH, and in those situations it's called Cushing disease. Normally, the hypothalamus, which is located at the base of the brain, secretes corticotropin-releasing hormone, known as CRH, which stimulates the pituitary gland to secrete adrenocorticotropic hormone, known as ACTH. ACTH then travels to the pair of adrenal glands on top of each kidney, where it specifically targets cells in the adrenal cortex. The adrenal cortex is the outer part of the adrenal gland and is subdivided into 3 layers: the zona glomerulosa, the zona fasciculata, and the zona reticularis. The zona fasciculata is the middle zone and also the widest zone, and it takes up the majority of the volume of the whole adrenal gland. The ACTH specifically stimulates cells in this zone to secrete cortisol, which belongs to a class of steroids, or lipid-soluble hormones called glucocorticoids. Glucocorticoids are not soluble in water, so most cortisol in the blood is bound to a special carrier protein called cortisol-binding globulin, and only about 5% is unbound, or free. In fact, only this small fraction of free cortisol is biologically active, and its levels are carefully controlled. Excess free cortisol is filtered in the kidneys and dumped into the urine. Free cortisol in the blood is involved in a bunch of stuff, and it's part of the circadian rhythm. Cortisol levels peak in the morning when the body knows we need to get up and go, and then drop at night when we're getting ready for bed. In times of stress, the body needs to have plenty of energy substrates around, so cortisol increases gluconeogenesis, which is the synthesis of new glucose molecules, as well as proteolysis, which is the breakdown of protein, and lipolysis, which is the breakdown of fat. Cortisol also helps to maintain the blood pressure by increasing the sensitivity of peripheral blood vessels to catecholamines, like epinephrine and norepinephrine, and this narrows the blood vessel lumen. Cortisol also helps to dampen the inflammatory and immune response by reducing the production and release of inflammatory mediators, like prostaglandins and interleukins, as well as inhibiting the proliferation of T lymphocytes. Finally, cortisol receptors are present in the brain, where their full effect is still actually unclear, but might influence things like mood and memory. For all this to work properly, though, the levels of free cortisol have to stay within the normal range. To do that, the body uses negative feedback, which means that high levels of cortisol tell the hypothalamus and pituitary gland to decrease their secretion of CRH and ACTH, respectively. Less CRH also tells the pituitary gland to make less ACTH, so the pituitary gland ends up having 2 reasons not to make ACTH. With less ACTH floating around, the zona fasciculata gets less stimulation to make cortisol, and eventually cortisol levels go back down to the normal range again. In Cushing's syndrome, cortisol levels are constantly higher than normal, so its effects are exaggerated. Excess cortisol leads to severe muscle, bone, and skin breakdown, which are the major protein stores of the body. It also leads to elevated blood glucose levels, and that leads to high insulin levels. Insulin, among its many actions, preferentially targets adipocytes, or fat cells in the center of the body, around the waist and buttocks. In those cells, the insulin activates lipoprotein lipase, which is an enzyme that helps those adipocytes accumulate more fat molecules. The result is central obesity. In addition to this, the high cortisol levels cause hypertension, and this is for 2 reasons. First, they amplify the effect of catecholamines on blood vessels. And second, cortisol starts cross-reacting with mineralocorticoid receptors, which normally only bind a related steroid hormone, mineralocorticoid, which are secreted from the zona glomerulosa layer of the adrenal cortex. In other words, because the cortisol is structurally similar to mineralocorticoid, it can bind to that receptor, and it can trigger the mineralocorticoid effect, which is mainly to increase blood pressure by retaining fluid. High levels of cortisol also inhibit the secretion of gonadotropin-releasing hormone from the hypothalamus, which messes up normal ovarian and testicular function. Excess cortisol also dampens the inflammatory and immune response, making individuals more susceptible to infections. Finally, high levels of cortisol seem to impair normal brain function, but the exact mechanism here is unclear. Cushing's syndrome can happen because of exogenous cortisol, meaning that it comes from outside, usually in the form of medications. But it can also happen because of endogenous cortisol, meaning that the excess cortisol is made by the body. The majority of cases of Cushing syndrome happen in individuals using exogenous steroid medications over a long period of time, often to treat autoimmune and inflammatory disorders, like asthma or rheumatoid arthritis. That's because the molecular structure of exogenous steroid medication is so similar to cortisol that they mimic its actions on various tissues. In fact, exogenous steroid medication can also cause negative feedback on the hypothalamus and the pituitary gland. This causes a decrease in CRH and ACTH, which in turn shuts down cortisol production from the zona fasciculata. Over time, this lack of stimulation can cause the zona fasciculata to physically shrink or become atrophic. Since that's the widest part of the adrenal cortex, it can have a measurable effect on the overall size of the adrenal gland. Even though this results in less endogenous cortisol production, it still doesn't quite compensate for the huge levels of exogenous cortisol, and that causes Cushing syndrome to develop. In addition to taking exogenous steroid medications, Cushing syndrome can also result from increased levels of endogenous cortisol. The most common reason for that is excess ACTH. The leading cause of that is a pituitary adenoma, which is a benign tumor of the pituitary gland, and this specific condition is called Cushing disease. The exact reason for the development of this sort of benign tumor isn't known, but unlike a malignant tumor, the cells don't invade neighboring tissues or spread to other parts of the body. Instead, the pituitary adenoma simply grows in size and secretes too much ACTH. The excess ACTH overstimulates the zona fasciculata of both adrenal glands, which grow larger and secrete excess cortisol. Apart from pituitary adenomas, there are ectopic sources of ACTH, like small cell lung cancer, and in these cases, the excess ACTH is coming from somewhere other than the pituitary. Another common cause of endogenous Cushing syndrome is tumors of the adrenal glands that make excess cortisol, like adrenal adenomas, which are benign tumors, and adrenal carcinomas, which are malignant tumors. In both adrenal adenomas and carcinomas, the cells of the zona fasciculata within the adrenal cortex start dividing abnormally and secrete excess cortisol. As before, the excess cortisol provides negative feedback to the hypothalamus and pituitary gland, suppressing both CRH and ACTH production. Although this doesn't have any effect on the zona fasciculata of the involved adrenal gland, since the neoplastic cells are autonomous, meaning that they've grown independent from any stimulatory signals, the zona fasciculata of the uninvolved normal adrenal gland shrinks and produces less than the standard amount of cortisol. The net result, though, is still abnormally high levels of cortisol, and that causes Cushing syndrome to develop. Regardless of the cause, the symptoms of Cushing syndrome are directly related to the effects of excess cortisol on its various target tissues. Resulting from the increased breakdown of most types of tissue, the individual presents with muscle wasting in thin extremities, skin thinning, easy bruising, and abdominal striae or lines, as well as fractures due to osteoporosis or brittle bones. At the same time, there's fat redistribution. So classic findings include a round, full moon-shaped face, a buffalo hump, which is a fatty hump on the upper back, and truncal obesity, where fat gathers around the abdomen and trunk rather than in the limbs. Finally, excess cortisol causes hyperglycemia, or high blood sugar levels, that can progress to diabetes mellitus, hypertension, or increased blood pressure, along with a high risk for cardiovascular disease, as well as increased vulnerability to infections, poor wound healing, amenorrhea or absent menstrual bleeding, and psychiatric or mental disturbances. Diagnosis of Cushing syndrome is initially based on measuring the free or unbound cortisol in a 24-hour urine sample, in order to assess the total amount of cortisol excreted in the urine over a 24-hour period. Alternatively, blood or saliva tests late at night can help check if there's a normal daily rise and fall of cortisol levels. Another option is also the dexamethasone suppression test, which is when a person is given a low dose of dexamethasone, which is an exogenous steroid that suppresses ACTH production in the pituitary gland. Normally, that should cause a decrease in serum cortisol levels, but if Cushing syndrome is caused by endogenous cortisol production, then the serum cortisol levels should remain unchanged. If that test is positive, the next step is to determine the exact cause of endogenous cortisol production. And ACTH plasma levels can be checked. Low ACTH levels can be seen in adrenal adenomas and carcinomas, whereas high ACTH levels can be seen in Cushing disease and ectopic ACTH production. If the ACTH level is high, the next step is to give an injection of a high dose of dexamethasone. Unlike pituitary adenomas, ectopic sites of ACTH productions typically don't respond even to high doses of dexamethasone, and the serum cortisol remains high. After all that, imaging can be used. An MRI of the pituitary gland in the case of Cushing disease, a CT scan of the adrenals when adrenal pathology is suspected, or a CT of the chest, abdomen, or pelvis if there seems to be an ectopic site of ACTH production. Treatment of Cushing syndrome depends on the underlying cause. If it's due to exogenous medications, then the offending drug is gradually decreased and eventually stopped if possible. It's important to avoid sudden steroid withdrawal, though, because that can cause an adrenal crisis, which is life-threatening. That's because the adrenal glands might be atrophied and might need months to recover fully, and during that time, the body needs the exogenous steroids to function normally. If Cushing syndrome is due to a pituitary adenoma, like in Cushing disease, then surgical excision of the adenoma might be needed. Alternatively, medications like adrenal steroid inhibitors, like ketoconazole and metirapone, can be helpful, especially for cases of ectopic ACTH production or adrenal carcinomas that have already spread. Alright, as a quick recap, Cushing syndrome is any condition or situation that causes increased levels of cortisol. It can be exogenous, meaning drug-related, or endogenous, meaning that it's from an adrenal tumor or excess ACTH from a pituitary.
So the next one kind of the hyperfunction of adrenal cortex is Conn syndrome or primary hyperaldosteronism. I hope you're familiar with the secondary kind of hyperaldosteronism. We already discussed about it when we talk about the cardiovascular pathology and about the renal pathology and about the liver failure. Usually secondary hyperaldosteronism associates with the activation of renin-angiotensin-aldosterone system. But primary type is associated with usually benign tumor of adrenal cortex, which is characterized by releasing high level of releasing of aldosterone. So let's see what clinically manifestations and what are mechanisms of Conn syndrome. Firstly, we have to differentiate types of tumors. It could be bilateral adrenal hyperplasia as in most common. Also, it could be discrete aldosterone producing adenoma, or sometimes, as in rare case, unilateral adrenal hyperplasia. And different types could be, it could be different, clinically manifestations. So some of patients suffer from only hypertension, and it's usually mild hypertension. So the systolic blood pressure 140 to 160 usually, but up to 20% is characterized by resistant hypertension, and more than 50% of the situation with Conn syndrome associates with normokalemic situation. And let's discuss about the clinically manifestation. It associates with the main function of aldosterone, which is participate in sodium reabsorption. So clinically manifestations associates usually with sodium retention, with increase of potassium excretion, and some group of the symptoms will be associated with this hypokalemia. So patient can suffer from fatigue with cardiac dysrhythmias. Sometimes it could be metabolic acidosis, muscular weakness, but sometimes it could be tendency to tetany. And usually we will see increase of hydrogen ion excretion, which also as an additional sign to development of alkalosis. When we discuss about the prognosis for such kind of patient, depends on this degree and level of aldosterone. So sometimes we have a favorable prognosis, but sometimes, unfortunately, it could be severe hypertension, and patient should be treated in time for prevention of different cardiovascular catastrophe, which is associated with this hypervolemia and increase of blood pressure. And the secondary, we've already discussed about it. So patients suffer from different disorders, but as a result of these disorders could be activation of renin-angiotensin-aldosterone system. So it works as a primarily usually compensatory mechanism or mechanisms of some support of cardiovascular system or mechanism for increase of cardiac output and venous return, but unfortunately in activation of renin-angiotensin-aldosterone system and different effects into inner organs such as myocardium and its remodeling, unfortunately has lots of negative consequences, and activation of this system became a way of pathogenesis. And let's move to the one more syndrome, which is also associates with hyperfunction of adrenal cortex, and we know this as an adrenogenital syndrome, which is characterized by or adenoma or even carcinoma of adrenal cortex, and usually we have to tell about masculinization among females and pubertas precox among males. And when we discuss about the clinical manifestation, firstly and most prominent is development of precocious puberty and appearance and presence of secondary sexual characteristics in children before the 8 years old. Very lots of pictures. I think that you can see it in additional literature, but lots of pictures of adrenogenital syndrome, and sometimes it's very dramatic. And let's move from the hyperfunction of adrenal cortex to the opposite situation, to the hypofunctions. So you have to remember that hyperfunction is Cushing syndrome, and hypofunction associated with Addison's disease. And Addison's disease is characterized by chronic insufficiency of adrenal cortex. But the same as in hyperfunction, here we can tell about primary hypocortisolism and the secondary hypocortisolism, which associates with the deficiency of ACTH. And let's see who suffered from Addison's disease.
He was so ill that his father had put cortisone treatments in safe deposit boxes around the country if he ever needed them because of his Addison's disease.
So what are causes of Addison's disease? Usually we have to tell about the autoimmune character of development of Addison's disease. And we have some kind of hereditary predisposition to these disorders. As in other causes, it could be tuberculosis, it could be infarction in adrenal gland. Sometimes it could be different infections like fungal infections or AIDS, metastatic cancer, and we already discussed with you about the acute situation with decreased intake of glucocorticosteroids. So do not forget about iatrogenic Addison's disease. Usually it characterized by development in both genders equally, and when we discuss about the ability of adrenal cortex to compensate some injury and some deficiency, disease symptoms of disease we will see when 90% of adrenal cortex destroyed. And you should remember that you have to ask anamnesis more beyond vita and patient carefully because of this association with tuberculosis or with some other infections. So what are the clinical manifestations? Usually patients suffer from weight loss, anorexia, some psychological slowing. This patient also can suffer from hypotension. Low level of aldosterone will lead to hyponatremia but hyperkalemia. Also, these patients are hypoglycemic and could be some other symptoms such as nausea, vomiting, or diarrhea. And one of the prominent symptoms of Addison's disease is the skin hyperpigmentation. And it could be hyperpigmentation in skin and also in mucous membrane. And usually it associates with metabolism of melanocyte stimulating hormone and with ACTH and glucocorticosteroids. So when we discuss about the mechanisms of hyperpigmentation, when we see decrease of glucocorticosteroids level because of some damage or injury, according to feedback control mechanism, it responds by adrenal pituitary, anterior pituitary, by increase of ACTH level. And ACTH, as you hope you remember, is derived from bigger precursor molecule, which is called pro-opiomelanocartin. And this pro-opiomelanocartin is also precursor for melanocyte stimulating hormone. So this link finally can lead to increase of level of melanocyte stimulating hormone and hyperpigmentation for the patients with Addison's. But here, this in clinical manifestation, we see hyperpigmentation only in primary Addison, in primary hypocortisolism, because in secondary, when the adrenal failure associates with low level of ACTH, no increase in melanocyte stimulating hormone production, so no hyperpigmentation. And sometimes Addison's disease could be characterized by development of acute complication of deficiency, and we know this as an Addison crisis. It's usually life-threatening situation, which caused by a sudden decrease of level of glucocorticosteroids. It could be triggered by surgery, some infectious or psychological stress. Sometimes it associates with venous thrombosis or with development of DIC syndrome or meningococcemia. And we know this in specific syndrome as Waterhouse-Friderichsen syndrome. Or this associates with iatrogenic or some with patient's mistake when sudden withdrawal from corticosteroidal replacement therapy. And Addison's crisis is characterized by sudden and acute hyperkalemia, hypoglycemia, weakness, confusion, and hypotension. Severe hypotension, which even can lead to the shock development. And this circulatory collapse is unfortunately unresponsive to usual treatment. As an additional symptoms could be GIT manifestations, such as severe vomiting, diarrhea, abdomen pain. Also could be development of acute renal failure and death. So in this picture, you can see this lady with Waterhouse-Friderichsen syndrome, which is associates with a hemorrhage and double influence into the both adrenal gland, and severe decrease, acute fall of glucocorticosteroids and other hormones of adrenal gland, and very dangerous and negative prognosis for this kind of patients. Let's move from the pathology of adrenal cortex to the disorders in adrenal medulla. Hope you remember that it's characterized by releasing of epinephrine and norepinephrine, and it participates in stress syndrome, and we know this kind of hormones as in fight and flight and fright hormones. When we discuss about the pathology of adrenal medulla, mostly it could be or benign situation with pheochromocytoma development or malignant with neuroblastoma. And the clinical manifestation of pheochromocytoma are very specific, and I think that can predispose even because the high level of catecholamines associates with increase of blood pressure, increase of the heart rate, and it also can associate with higher tendency and higher risk of development of different cardiovascular catastrophe. So pheochromocytoma mostly produced from adrenal medulla. It's the 90% of such kind of patient, and in 10% it could be paraganglioma from sympathetic ganglia. Also could be different situation. It could be bilateral or extra adrenal kind of, and in 10% it could be malignant tumor. It could grow rapidly, and even benign tumor could have kilo or even more mass. And clinically characterized by paroxysmal, usually this hypertension with fear of death, and with other hallmark of increase of adrenaline and noradrenaline releasing. Usually this patient characterized by very severe hypertension. Blood pressure, systolic blood pressure could be 200 and even 250 millimeters. This patient should be diagnosed in time, because such a high level of catecholamines finally leads to increase of the afterload into the heart. It's characterized by myocardial hypertrophy, tonomyogenic dilation, and high risk of development of congestive heart failure. So these patients should be diagnosed in time and should be treated in time. Usually it's different kind of the surgery. And very close to this, very close, I mean, from the pathogenetical point of view, to endocrine system pathology topic is the stress topic, because both of mentioned before hormones like cortisol, which is a main stress hormone, and catecholamines too, we will see releasing in stress. So usually it's according to the author of the theory of stress, Gans-Selye, we have to differentiate stress into different kinds. It could be eustress and distress. And when we discuss about eustress, it's the good idea which help us to survive, which help us to reduce inflammation, which help us to increase of cardiac output. It help us to get more energy when we need it, and which helps us to survive. And unfortunately, when we discuss about the influence of stress, we have to divide it into the acute and good stress, which usually long term and short term, and which is usually characterized by presence of lots of positive things for us. But sometimes we have to deal with the chronic stress, which is in long-term persistent and which is characterized by development of depression, anxiety. Sometimes it could be long-term abuse or some emotional exertion, which finally leads to exertion of the adrenal cortex with an exertion of level of cortisol, with negative influence of this into the endocrine system, and which finally can lead to negative outcomes for the patient. When we discuss about the pathogenesis of stress, it associates with the final effects of catecholamines and glucocorticosteroids. So everything associates for increase of energy production, increase of blood glucose level, releasing of endorphins associates with decrease of pain. And again, let's see that in stress situation we have some reserve which gives us higher energy level and gives us oxygen supply and helps us to avoid danger. Unfortunately, we have some kind of negative influence from acute stress, and about the pathogenesis of stress ulcers we already discussed with you when talk about the GIT pathology. And in long-term situation, unfortunately, negative influence and distress as one of the most prominent causative factors for different kind of disorders, since some functional problem till morphological, till the situation with decreased immunity, increase of risk factor for development of malignant tumors, etc. And if we make some scheme about development of the stress, and we'll divide duration of stress into different stages, which are alarm stage, resistance stage, and exhaustion stage. Let's see that this with an acute stress situation, usually alarm stage, and then we go to the resistance. But chronic stressors finally leads to exhaustion, and it leads to damage of inner organs. It leads to prevalence of infections because of immune deficiency. It can characterized by dystrophy of myocardium and characterized by exhaustion of the energy stores. So what we do and what we have to do about the chronic stress and how can we deal with this? There are two variants, I think, and now we also in some stress condition about this pandemic situation. But we have usually there are two variants, or if we can, we have to remove the stressor. But sometimes we cannot do this, so we have to effectively cooperate with the stressor and avoid this negative influence of the stress into our organism. So I think that it's enough for today, and thank you very much for your attention, and see you next time. Goodbye.